So this is going to be overview of opioid use disorder. I am stepping in for Dr. Snehal Bhatt. Not nearly as good looking, but hopefully we'll be able to have a little bit, bring some knowledge to you. And he sets a high bar. So we're going to talk about the FDA approved medications, and and in 2023, we got another with Brixadi approved. So we have 2 injectable that are available, and I'm hoping that comes down in price and is easier for insurers to cover. And then to choose between the different treatment options. I think if there's one thing that I want to get out of the talk or stress is that it's not one size fits all for different people. And then have a comfort for medication-assisted therapy in treating opioid use disorder. So I think step 1 is detox alone does not work. In 2023, this seems to be less of an issue than it does 5 and definitely 10 or 15 years ago, where detox is basically where we bring somebody in, get them off their opioids, titrate down the medication, and say, hey, good luck with life. There's a lot of relapse, and opioid-based abstinence programs. It was actually a big increase in death was coming out of one of these things. So when we're detoxing, I think we want to advance our thinking from that. This is and part of this also gets into talking about some of the studies and how long they've done. So one that's not in here, but I think is actually important that I use is in 1970, when Nixon declared war on drugs. Part of the thinking was we need to help people get off of the drugs that doesn't involve like tie them down and make them go through withdrawal. And so we had methadone initially was used for detoxification purposes. That was a huge disaster, and legislation was needed to fix that. And so by 1973, we had the framework for a methadone clinic, or what we in the professional business called outpatient treatment program, or OTP, to allow for long-term methadone use. There have been several studies that have looked at and demonstrating this a short-term approach unfortunately does not work. And so at this is just one of multiple studies that was done. I think I like it, and we continue to use it because it was a large study done in Lancet and followed people for about a year. And interestingly enough, in 20 years after this study, we still don't have any new published data that go beyond a year demonstrating does opioid or MOUD work beyond a year. But really, the Keiko study formed the basis of making it essentially standard of care. And the thinking is, from an ethical standpoint, that a patient really is on the medication for as long as they feel that it benefits them. In my opinion, this is kind of like if you develop diabetes in your late 40s, early 50s, and you got that whole metabolic syndrome, and the answer is, do you need to be on diabetic medication for the rest of your life? My answer is no, but making the diet and exercise modifications is oftentimes tough. And I think, again, what we need to set our patients up for success for them, for their families. And the same line of thinking is, could you get off? Yeah, of course. But let's get life back together. Let's get things satisfied first. And so here's kind of where the role of medications come in on a long-term basis. So methadone and outcomes, and decreasing heroin use by 50%, HIV, decreasing the infections, increasing employment, decreasing criminal activity. And I want to just kind of emphasize the cost savings with criminal activity. So prior to the pandemic, incarcerating somebody was $35,000 to $45,000 per year per inmate, plus the court costs to prosecute that case. And then more often than not, the court costs to defend that case too are all spent by the state. And the question is there a better use of those time and energy for people. And even if they're working at the greasy spoon down the street as a dishwasher, they're still paying into taxes. So, and not so much dependent on the system. Improving child support. As I go through this, we have the key of mortality, obviously the survival benefit, but what in medicine, any other treatment modality that you can think of that has this broad of outcomes for doing? The survival alone benefit by the X-wave or the old X-waiver course slides are demonstrating the 66-70% survival. Again, there's really very few things in medicine that we do that has a survival benefit anywhere near that area. The one obvious one is I'm going back to diabetes, but insulin for juvenile or insulin-dependent diabetes was a death sentence before that. Some more benefits is that have been shown to getting people into and maintaining treatment. Again, just increasing a lot of safety overall. Decreasing crime. This was one of my actual, this is not my study. This is before I was in medical school and was still just had a nursing license back in '98. I'm dating myself at this point. But one of my first studies when I got interested in addiction was actually looking at crime as well, and how overdose deaths and drug use is associated with an increased risk of crime. So more food for thought. Again, really medications are the driving force. The term MAT that we've all kind of grew up and kind of knew, medication assisted therapy, really because of these outcomes has fallen out of favor for medications for opioid use disorder, and having therapy more assist. With that said, I think the presence of, I always say that in medications are the workhorse here, but really having a therapist, somebody like Evelyn, is really, really helpful when the patients are ready for that and getting into the underlying cause of why are they using in the first place. So the first medication that we're going to cover is methadone. It's a Schedule II drug. It's highly regulated. I don't see major changes in, we're not seeing the legislative changes at the federal level like we are with buprenorphine. But since I have the floor and this is being recorded, you're not allowed to talk at this point, I think we need to deregulate some of the methadone. With that said, there are some more increased risks because of methadone having a very long half-life, and by accumulating with active metabolites in the body, it also causes QT prolongation. So who's it appropriate? The advantage of methadone that's not on the slide is it's dirt cheap. So it was originally developed by the Nazis in Germany, and let's just say we've ensured that the Nazis won't profit on methadone. And so this is really, really inexpensive. Pennies on the pound for it. It is regulated in our opioid treatment programs, and patients basically need to be 18 or older. We can apply for an exception if they're under the age of 18. And so I kind of put it that asterisk by the 18. Most methadone clinics would actually won't see anybody under the age of 18. And they also, the other thing, part of the regulation is they require this 1 year of documented opioid dependence. Some patients meet in their mild or early opioid use disorder may not actually meet that. So maybe an exclusion criteria too. Just again, kind of the nuance of this. There are several barriers. I think one of the biggest challenges is just getting into the clinic on a daily basis. And whereas I think for some people, there's a value. I've had one of my patients, I don't know, I refer to all my patients as my favorite patients, but one who is doing well on methadone, and daily check-in is actually really helpful for her, because it gets her out of bed. And once she gets, and she knows that if she doesn't make that, she's going to feel terrible. And then once she's up and going, then she gets to work and the rest of her day, and she's productive. Whereas if she didn't have to get up, she described she wouldn't get out of bed. My other thought is people coming off of the street. They may not have any positive interaction with people. I mean, I don't want to go live on the street probably for the same reasons you do. It's a very unfriendly place. And just having somebody, I'll talk, our security guy at ASAP, his name is Phil, and he's a big friendly guy. And he greets everybody by name and will talk to people. And so people are seeing what a healthy relationship looks like, or a healthy interaction where, Phil's not trying to screw somebody over to get the drug out of them. And I think that's helpful from a psychology standpoint to help with their health. But again, the location, if I was living in Cuba, New Mexico, or my favorite place to always give the example is Lordsburg, New Mexico, like getting treatment out in Lordsburg is a bit of a challenge, because it's, if you didn't know, it's about half hour, 45 minutes minimum to the nearest hospital. Cuba, I guess, is an hour. And so changing gears a little bit to buprenorphine, we were first allowed to use buprenorphine for opioid use disorder in the year 2000. I don't want to get into all the regulatory changes, as there are many. And the biggest one came a year ago, where we get rid of the X waiver completely, and that anybody who can write for a Schedule III can write for buprenorphine. The caveat in giving that up is that now you need 8 hours of CME unless you're just graduating from medical school or residency. I have 2 medical students in the room with me, and so if I'm looking off to the side, I'm acknowledging they don't have to do it. But we've set this course up to be included into counting for one of your 8 hours to renew your DEA license. So buprenorphine, it's a partial agonist, and that partial agonism we all learn in pharmacology school or pharmacy school, medical school and pharmacology. There we go. But it's fairly significant and has some real important clinical properties. Number one is buprenorphine an otherwise healthy adult that's hard to overdose on and have a bad outcome. As we're seeing with the fentanyl era, and even in the heroin era, there is this suggestion that's been advanced by multiple people that it may also help protect you in the set of an overdose, that the buprenorphine binds to a higher affinity than fentanyl or heroin or Oxycontin to that mu receptor, and maybe slower to kind of dislodge it. And so we may have some protection. But on the other side is that partial agonism may induce people into some level of withdrawal when we're initiating the drug. So there's a fair amount that's written on the package insert on how to introduce buprenorphine safely. The problem that we find is that getting a COW score of 8 or 9 that we really need is hard for a lot of patients to be that uncomfortable. So we've started doing some of the microdosing and some of those. So stay tuned for, or keep coming back to some of the other echo series or echoes of this, and we'll go through those as well. Also, one of the things for help here, the Poison Center, and this is only for New Mexico, and Rachel will put the phone number in the chat, but we're the only poison center in the country doing it, but we've been taking addiction call for 3 years. And then it's myself, Eric Ketchum, or Sergio Huerta, so all backing up our pharmacists, taking those calls, and we're happy to help with any patient call that you have on buprenorphine or in the induction. Office-based induction, I think, is the standard of care at this point. Outside of pregnant women, it would be unusual that we bring somebody into the hospital to do the induction. Pregnancy is a bit of an exception because it is believed that opioid withdrawal is an unsafe, or puts unreasonable fetal strain and we want to try to avoid that. So office-based treatment, and I think this is a part of the changing time. So everybody on the call, again, who can write for a Schedule III drug, can initiate somebody on buprenorphine. Somebody doesn't have to show up at a clinic that says addiction program or something, and to hopefully bring people in, and just the feeling of the stigma associated with it. I here in Albuquerque, one of our and I may share this example. One of our judges who's on the bench is in sustained recovery. We have full professors here at UNM and things. And the thing is people in recovery look completely normal. And that's a beautiful thing about the recovery. It also, we can decrease some of the cost of doing it. The other challenge here in New Mexico is we have a real shortage of inpatient beds. And a lot of the inpatient beds that we have had historically have been in absence space. A lot of our patients are uncomfortable or don't want to go into the inpatient program. So doing home inductions really, I think, is the way I do it most commonly. Basically, looking at the Cochrane review, as a cost basis of a meta-analysis looking at 8 different studies. This is a little bit older now, but methadone, the people were more likely than bup to retain their patients with that. Naltrexone, this is kind of the third medication that we have, and I think it's oftentimes a forgotten medication. So the naltrexone is a full-on antagonist. And I think we tend to forget it because getting somebody with opioid use disorder stabilized on naltrexone is a bit of a challenge because they have to go through that first month is usually pretty miserable for them, and they've got a lot of intense cravings and things that they're just like, hey, no, I don't want to do it. When we get somebody, especially through their second month and into that third, and then we start really seeing very similar outcomes with methadone and buprenorphine. Another of my favorite patients came to us, or came to me, and he had failed methadone, he had failed buprenorphine, and he had been in recovery himself for about a month and did not want to go back on methadone or buprenorphine, and as doing great on naltrexone, and comes in once a month for a shot, and has been in sustained recovery for more than a year. People that I know who know him around here, he is one of these people who has the cycle of doing really well and then relapsing, and then we just go through the cycle, and this is the longest he's ever been into a sustained recovery. There was a new article, systematic review of the literature in JAMA that just came out looking at the FDA approved treatment for alcohol use disorder, and with acamprosate disulfiram, and just touching on current events. Naltrexone worked the best for severe alcohol use disorder, and disulfiram had like no clinical efficacy, which I thought was interesting. And yeah. So how do we choose? I think step one is involve the patient in the decision and understand the limitations that you have. So, you know, I have the privilege of working at ASAP, so I've got everything available to me, including methadone. But I think as the outpatient clinic, our choices are really naltrexone and buprenorphine. And I think with the REMS program, which I understand why we have it, is it makes some of the delayed or the sub-Q or injections of buprenorphine a little bit harder to obtain for some of our patients. I think, again, going back to this, really needs to be a patient-centered approach. And what has the patient tried? What do they have an experience with in the past? What's worked for them? What hasn't? But most importantly, when the patient feels the hope and the excitement, their success is a lot better. And so we're running short on time, and so I'm just going through some of the slides a little bit quicker. How long do I want to stay in treatment? I tell patients, let's stay a year, because we know that for scientific data, and let's reevaluate after a year. There's going to be another study that we're wrapping up enrollment on, where we've looked at people who are a year or more and are expressing an interest in wanting to come off in a couple of different ways that we're doing a clinical trial on. So more to come on that.